Mark Eliason is a practicing dermatologist at the University of Utah, Department of Dermatology, where he completed his MD and residency in dermatology. Mark was a fellow with PC Project under the direction of Sancy Leachman during 2005-2006.
So I'm going to give a talk this morning about living with pain in the context of PC. I had a chance to give a similar talk earlier this year in San Francisco. I really appreciate the chance to come back and talk again. It's great to be back with these PC patients. I want to first give you some of my qualifications and limitations in giving this talk. I'm not a pain specialist. There are doctors that are. I'm a clinical dermatologist, but as we keep going back to this fellow thing. When I spent a year doing work with Sancy and with Mary with PC, I saw a lot of PC patients, read a lot of the questionnaires, examined a lot of people, and talked to them. And that's the basis kind of for what I feel is the understanding that I can add about PC. What I want to do today is talk shortly about what makes Pachyonychia Congenita hurt. I know it's kind of a funny thing to tell people who have it why it hurts. You already know it does. But I think it'll be a little bit helpful to go over that. I want to talk a little bit about the rationale for a lot of the treatments that we use, that PC patients use for their treatments, because sometimes if you know why something helps, we can start thinking about, well, maybe if I did this instead, it would also help the same way. I'm going to talk about modifying PC pain, this is the fun part. This is the part where you guys have to participate. If you don't, it's going to be really dry, boring talk. We don't want to do 20 minutes worth of that. That's what the red and green cards are for. I'm going to talk a little about, kind of just from a doctor's standpoint, how to safely use home medicine to treat pain if you need to, and then also talk about what other things doctors can recommend and can do for you to treat pain, since some things you might have already done and some things you haven't. I'll be asking you to share some of your experiences, some may be a little personal about maybe some medicines you've used or haven't used. I hope that you can feel comfortable enough to share that, but I don't want to make anyone uncomfortable. So to the extent that you feel comfortable, please participate. I do have to acknowledge Dr. Peter Holt, who's one of the dermatologists in Canada, who actually came up with the idea of the audience participation in some of the same slides. He has kindly said I can use anything I want to, but I thought I should at least show you who he is, who gave all the good ideas. Anything that's good, he thought of. So you have a red and a green, or maybe a pink and a light green card with you, around here. And what we're going to do is we're going to have you participate when I ask you a question by raising the card. A green answer is affirmative or yes or I agree. Red means I disagree or whatever, and that's okay to disagree. The idea here is that if I tell you something, you'll forget it. If I show you something, you might understand. And if you participate, you might take something home. We're going to go for that one right there. Okay, we're going to practice with the cards. Get your cards ready. Here's our first statement we're going to practice with. The statement I'll say is, I live in Salt Lake City. So, agree, disagree. Okay, lots of red, a little bit of green. Perfect. Okay, I think you got the idea. Now, okay, thank you, that was great. Now we're going to try, okay, and then your picture. Okay, so now we're going to try another one, and this is a little bit more to what the talk is about. I am in pain now. Agree or disagree? Okay, and look around when you see it, just to get it, because this is the point, is for you guys to see what everyone else is saying. You may not have time to talk to anyone, but you'll have time to see what everyone says. So, thank you for that. What's interesting is that when you're sitting down in a seat, PC patients will have pain. Not everyone will, but some will. PC patients have pain, and some of it's easy to, I think is easy to understand. Some of it's hard to understand. This is coming from a doctor trying to explain something. What's easy to understand about PC pain? Well, if you have a nail infection, well, that makes sense. That hurts. You may be damaging nerves, or you may be putting pressure on nerves by swelling. That hurts. An inflamed cyst hurts. You're putting pressure on nerves again. Blisters hurt. Again, you're pressure and damage to nerves. Doctors don't have a problem seeing someone who has a nail infection and saying it hurts. What's hard to understand? Okay, calluses. Why does a callus hurt? A callus isn't supposed to hurt. That's what forms them. They're supposed to protect you, and they're rough, and they have no sensation. When I went back and looked at these old papers that were published 100 years ago, 80 years ago, 50, 20, even 10 years ago about Pachyonychia Congenita when I was a fellow, almost none of them talked about Pachyonychia hurting. They talk about the clinical findings, but they say, oh, some discomfort is experienced. Yeah, some discomfort. I think the problem is that a lot of doctors look at this and they see these calluses and they think, okay, he has a callus on his foot. And they don't say, wow, that must be incredibly painful, because that's not what you usually expect when you see that. So this is when you're trying to rate pain, it's hard to do because pain is differently experienced by a lot of people. When I do a blood test, I can say, wow, your sodium is 142, or your glucose is this. I can't do a blood test and say, well, your pain is a 6 today. I have to ask patients and be able to engage them by helping them to quantify what their pain is to understand it. Some doctors have spent a lot of time trying to figure out exactly how to quantify pain, and they come up with these intricate questionnaires that you can ask, like say, take a bunch of people who have shingles, which if anyone's had that hurts a lot. And you ask these questions, and you can take those answers and turn them into a number. And for example, on there's scientific study that was done where they took this pain scale, and they rated pain from 0 to 50 based on the scale. People that had shingles were about a 24 based on that, so that's pretty painful. People that were in labor and delivery rated as about a 34 on that. People that have actually delivered children probably tell me it's a lot higher, but that's what this that's just what it said. I'm not trying to tell you. That must be an average. You know, breaking a bone, sprain, arthritis, and amputation obviously is quite high up there. Now, in Dundee, they did this same pain questionnaire. It was given to 10 PC patients. They asked them the exact same questions in a very methodical way. And what was really interesting is that the answers came back ranging from about a 7 up to a 34. And so these people all had the same condition, right? But look how varied that reaction was. This line shows you what the average was. So it's apparently, according to this, it's better than breaking your bone, but it's worse than having a sprain. But that's the average. So you can see how varied it is. The point I want to make before I go farther is that PC pain is a very unique experience. Sancy made this point at the end of her talk as well, that we know that the different genes that are associated with the PC show different manifestations in the skin. And so if you have a mutation in a certain gene, it may make you have a tendency to maybe have thicker calluses or more cysts. If you have mutations in different genes or in different parts of the gene, it may well mean that certain people have more pain, even with the same clinical findings, meaning people can look the same, but have a very different amount of pain, not because they're weak or whatever, but just because it may actually be in the genes. We don't know yet. We're trying to figure that out. So I want you to take that again into consideration while we're sharing our experiences, while you're seeing what other people do to help. You may find people that they do something and they say it just helps remarkably, and it may not help you, and not because there's anything wrong with you or right with them. It just may be that there's a slight difference. We're not smart enough yet to know what that is. Yeah, and then this is just when doctors approach pain, it'd be nice if we could just tell you if you hurt or not, but we can't. So just some take-home points is that PC is often associated with pain, and it varies among patients who have it. So let's get to the next part here. So yes, you have pain, that's depressing. What do we do about it? When you approach someone in pain, there is a methodical way that you try to change that. First thing you do is you try to fix what's causing the pain. We're still working on that. We haven't got the cure, the treatment for PC yet. But when we do, we'll go to this first step, which is the best one. If you can't get rid of what's causing the pain, then you try to first find out what minimizes the pain and also what accentuates it, and either avoid or engage in those activities to try to moderate it as much as possible. Once you've exhausted that ability, the next step is to treat the pain directly if that pain is still interfering with the activities you want to participate in your daily life. And that's where you do physical interventions and medical interventions. So I'm going to talk about this part first. I'm going to also use foot pain as kind of the example of what I'm going to talk about, because I think that's a very common experience that might be better appreciated by everyone. So going through the IPCR questionnaires that people have filled out and sent in, the registration forms, I pulled out some examples of what people say makes their pain worse. And some of these may apply to you and some may not, but these are examples of things that a lot of people say make a difference. There are also things people say that make it better, like cold weather or resting. So I think maybe you guys can appreciate that there are things like that. The first step, again, find things that make it better, find things that make it worse. And then the other things people talk about is not just the environment, but also things that they can do. You can, callus removal or grooming the callus, finding ways to decrease the amount of sweat on your feet if that's helping, if that is making a difference, or decreasing the weight, and then using drugs legal for the pain. First thing I want to talk about is callus removal. These are examples from PC patients all around who told us what they do. So they groom their calluses. You can go to see podiatrists that can do it with you. You can use Dremel tools. Actually, there's a number of people that do this as well. Pumice stones help. People have suggested using razor blades, and then also these microplane kind of razors to help out grooming the callus and getting it thinner. So, get your cards ready. In your own experience, do you agree or disagree that shaping or removal of the callus improves your pain? So, kind of look around for a second, kind of see what people are saying about that. Okay. So, Interestingly, so a lot of people say yes on that, but there are a few people that say it doesn't make a difference. So interesting to note that. In addition to physical modalities to remove the callus, you can also use chemicals, and these are lotions and creams like salicylic acid, urea-containing creams, ammonium lactate. These are all over the counter examples. There are prescriptions like Tazorac and Retin-A that also help modify that. And so I want to ask you about these. So first, the top three. So using the over-the-counter creams, has anyone found that these creams are useful in helping them? Take a look, too. That's interesting. So kind of a mixed bag. We have roughly, I'm going to guess, about half and half. Some people say it does help. About half people say it really doesn't make too much of a difference. So the other ones, now the Tazorac and Retin-A, the prescription ones, if you've seen a doctor and had these prescribed for you, if they've been prescribed for you, do you think they've helped? So.
Can someone take a picture? That's pretty unanimous.
Yeah.
So can I just take
Sure.
1 second? We have a patient from Serbia, just came last week. Letter from the doctor, saw the patient first time, immediately prescribed Tazorac. Patient found it burned and quit. The doctor's like, should I help? But he didn't see this vote, did he? So does that patient need to use Tazorac? That's what we've got to get out.
It needs a red color.
It needs a red card. Take these to your doctor's office and release you. They'll help with communication. Okay. So those are some of the chemical modalities. I want to talk now about some of the other things people talked about with pressure dispersion. So as you guys know, when you see a foot, when you stand on it, most of your pressure is not on your foot uniquely. It's actually basically focused on your heel, the balls of your foot, and then on your big toe. That's where all the main pressure is. And PC patients can actually show me this without these neat little barograms, because you just look at their foot where the callus is, and you're like, wow, there we go, it didn't need the computer. Now, some people use orthotics and insoles. Now, this will make sense, because what we're doing is you're taking, on this top one, here's a foot, and you can see where in the heel of the foot, there's no pressure there, but there's a lot on the ball of the foot. Now we spread the pressure out, and it's not as intense in that area. So this is the idea, as you guys have all figured out on your own, probably, why orthotics or other weight distributing approaches help. That being said, in your own experience, are orthotics helpful, yes or no? Does it make a difference? Okay. Interesting. Okay, I'm just going to kind of summarize. It looks like it's about 3 to 1 yes, but some definite groups that say it doesn't make a big difference. Now, in addition to orthotics, there also can be specially modified shoes where the sole might be a little bit different, the sides of the shoe might be different. You have your favorite pair of shoes. Does that make a difference? Do you have special shoes that you use? Okay, almost everyone's got a special shoe. There's a couple exceptions, people that the shoes don't make a difference for. Okay. Leaving some of the physical modalities, I want to ask you about behavioral modifications. This is avoid what makes it worse. So what I did here is I took some direct quotes from patients who had written in when I went about what makes this worse and what makes it better. Just thought it'd be fun to share these and see what your experience has been like. So this person says when they wake up in the morning, what makes a big difference for them is they put both their feet on the ground, they sit there with their both feet on the ground for a few minutes, and then they get up. What do you think? Has anyone tried that? Said it makes a difference or not? So we're split about halfway on that one. Okay, this is very important to this person. Keep your feet uncovered in bed. You never wear bed socks. Okay, that's almost unanimous on that one.
Except the Clarks.
There's the Clarks in bed. Oh, Jan. We can do that, Jan.
The anonymous people in the back row.
We're going to announce what Jan goes on everyone from now on. Yes. Okay. Okay, I use talcum powder or foot antiperspirant, something to keep the sweating to a minimum on my feet. Who has found that does or does not make a difference? Okay. Okay, interesting. My thought was actually it's different than that, but it looks like not quite. Looks like just over maybe 60% or so say that is not too helpful. Okay, I drain blisters. Now these aren't blisters on your fingernails. These are foot blisters. I drain them as soon as possible with scissors or a needle.
What if I just use my hand?
Go ahead. I see you both. Okay. Okay. Wow. Okay, that is actually completely unanimous. So that makes a difference. I soak my feet in warm water.
Does the shower count?
Are you?
Yeah.
Yeah. We'll give it to you. That is okay. So that's interesting. That's about 2/3 yes, 1/3 not so much of a difference. Okay, I get a good night's rest, at least 8 hours every night. Makes a difference.
What if we want?
Here's the purple card. Okay, that's almost unanimous. I have to confess, I looked at that one and I thought, wow, I don't see why that would make a big difference. You know, everyone dressed, but unanimously it makes a difference. Obviously, some of us aren't smart enough to figure that out on their own. Okay, I like this one. Okay, so red wine, medicinal, of course, helps me cope with the pain of walking, such as climbing the Eiffel Tower. And martinis are also great. So those of you who have experienced this medicinal intervention, about half and half to help with that. Okay.
You better be red, Sam.
Not thinking.
All right. Meditation and prayer allows me to make it through a working day. A more introspective approach. Okay, wow, and that plays a big role for most individuals. There's a couple it doesn't make a difference for too. Okay, thank you. That's the first part I wanted to go out, and then I wanted to just in a few more minutes here talk a little about some medical interventions. So I'm going to do a quick education on some medicines we've been using most of our life from a doctor's point of view, and kind of go from there. Just like this picture, we see doctors are kind of pill pushers sometimes. So got to throw it home. Okay, painkillers. There are two main groups of painkillers. There are over-the-counter painkillers, and then there are prescription painkillers. And I'm going to break the over-the-counter ones down into how they work and how to use them, and also the prescription ones down into different groups depending on how they work as well. First question, do you take any kind of painkillers on a regular basis to help with your PC pain? Okay. So about 2/3 yes, about 1/3 no. Okay, first I want to talk about Tylenol. It's also called, Acetaminophen is the generic name for it. This has been around for over 100 years. We've used it for about 60 years. You have to distinguish this from things like ibuprofen or aspirin, because this is a painkiller. It's not anti-inflammatory, which the other one is. We actually don't know how it works, which is kind of cool. Had it for 100 years, never figured out how it works. It has a central effect, though. It works centrally in the nervous system. It doesn't have a peripheral effect. It doesn't work if your foot hurts, the Tylenol is not helping your foot. It's helping centrally your perception of the pain of the foot. The good news about Tylenol, it's safe at the recommended doses. It's easily available, and it's not habit-forming. The bad news about Tylenol, it is as a slow onset of action. For most individuals, it's about an hour after you take it before you have the peak onset. They have new formulations, well, not really new, but they have formulations in gel caps and such, which are supposed to have a more rapid onset. In most individuals, you can feel the full effect of it better. But as a general rule, it takes a little while to feel it. There's a ceiling effect, and that means that after you get above a certain dose of Tylenol, taking more doesn't help with more pain relief. And then at high doses, especially if Tylenol is taken concordantly with alcohol, because they're both metabolized inside the liver, you can actually have the potential of getting liver damage. Tylenol overdose is the #1 cause of ER visits for overdose of any medicine, so just keeping that in mind. Yeah. But we're going to talk about dosages, and so you can be confident and safe about what you take. So, I take Tylenol to help with my PC pain. Yes or no?
Clarification. We take Excedrin, which has that in it. Do you want us to answer?
Yes.
Excedrin is actually...
Because I'm actually not doing Excedrin because it's a combination, like you guys know. So.
Right. So you want us to answer for each one?
Yeah, answer for each one if you do. Okay. All right, so that's about maybe a quarter yes, 3/4 no for Tylenol. Okay. Now, NSAIDs, this is a bigger group of medications. This is where I put Excedrin in here. So aspirin is an NSAID. Ibuprofen, which is Motrin, and Advil is an NSAID. Naproxen, which is naproxen, is an NSAID. Aleve is naproxen. And Excedrin is a combination of aspirin, caffeine, and Tylenol altogether. These stop pain centrally, and they also have an anti-inflammatory effect, usually at higher doses. They prevent inflammation. That's why people treat arthritis with it to help with the pain and the inflammation. For those of you that are into biochemistry, this is how they work. You can see me afterwards if you want to know more about that. The good news is NSAIDs are, again, safe at low doses. You don't need a prescription, so they're easily available, and you can't form habits with them. As a rule, most doctors feel that NSAIDs are a little stronger pain relievers than Tylenol, as a generalization. The bad news is, like Tylenol, they do have a ceiling effect, which means more doesn't always give you improved relief beyond a certain point. They also have a relatively slow onset of action. They do have certain side effects that if you take higher doses for a longer time, they can cause stomach upset. They can thin the lining of the stomach, and you can get like gastritis, which is pain in your stomach. They can also make it a little bit easier to bleed because they stop clotting from happening. And they can also, at really high doses, they can interfere with kidney functions. So Tylenol, liver, NSAIDs, kidney. That's important later on.
Dr. Mark, what do you consider high dosage?
I'll go specifically. It's a good question. Okay, I take any NSAIDs regularly for pain. Okay, interesting. So this is more about half and half I'm estimating here for the NSAIDs. Okay, so let's talk about safe doses. So these are calculated with the idea that everyone weighs about 155 pounds. So take that into consideration. Every 6 or 800 milligrams every 8 hours. Over-the-counter preparations are usually 200 milligram tablets. So what I'm saying is that you can actually take 4 tablets of Tylenol, of the ibuprofen all at once every 8 hours. And that's considered a high dose, but still within the safe range. That's when they say, if you're going to take more than this, consult with the physician. This is what the physicians would tell you. Now, if you have a kidney problem or you have any other issues going on, this gets changed. But for a normal, healthy person, these are the doses that are okay. Yeah?
Will that be written down any place?
I don't have it written down anywhere. We usually have this up on the web, and I can write it down for you afterwards.
We can make all of these slides and presentations available, and we'll also send out
Okay.
Dr. Hall, Dr. Eliason.
Hey, Mark,
Yeah, Sansi.
you want to mention about, that it reduces the gastritis side effects if you take with food and...
Oh, that's a great point too. Yeah, so talking about ibuprofen, Sansi's point, if you couldn't hear it, was when you take ibuprofen, it's always best to take this with food. The reason being that it reduces the amount of and the how fast you may develop some of those irritation in your stomach. Okay, so that's an important part to make. Also, taking these when you're dehydrated is generally not a good idea because if you're dehydrated, it can affect how well your kidney processes them. So. Good meal with some liquid is always a good way to do it. Yeah.
I was told at one time, maybe when I was studying anatomy and physiology, that chemically it's easier to prevent pain than to get rid of pain.
Yes.
So I tend to try to take painkillers prophylactically, but I'm always concerned that would I really need them? So what is your recommendation on that?
Okay.
And is that true?
First of all, what you're saying is exactly true. It's always better. When you play catch up with pain, it's harder than than preventing it in the first place. There are very good studies, and they do these on a lot of surgical patients who say have they get their gallbladder out or something, and then they use morphine and other stronger pain medicines. Doctors who put them on a continuous low dose of morphine or some other painkiller afterwards. And ultimately, those patients require much less pain medicine than patients who are, the nurses come by and say, are you in pain, do you need anything? And they have to catch up to it. The same rule applies also with these kind of pain medicines. Sansi?
I just have another comment, though, because that, there's two ways of looking at that. Because in arthritis studies out in the real world, so what you're talking about is in a hospital setting where there's been a procedure and there's a definite transient pain that's going to be happening. But the other thing about it is in arthritis patients, when you pre-dose, right, when you say you're going to go on a hike, but you know you're going to be out there, your feet are going to hurt, so take the ibuprofen before you go on the hike. It does reduce the pain, but it also then decreases your capacity to be aware that the pain is happening, so you sometimes experience a worse after effect after having medicated before the event, because you do more than you would have otherwise done. Your normal body feedback would have told you. So, and I'm not saying which way is better or worse. There's no judgment call there. It's just that happens.
Right. So then that brings up the point, there is a reason why we have pain. Pain is to tell us to stop doing something that we're doing. That's our body's way of talking to us. And Sansi's point is well taken, that if we turn that off or turn it down a little bit, and we're not conscientious of that, we can exert ourselves to the point where now we've caused more damage than we would have before. So that's an important thing to remember. Your last point on your question was, how do I recommend that we do that for prevention of pain? And I'll talk about that a little bit, but maybe I'll just talk about it now instead. As a rule, when you're treating chronic pain, which is what Pachyonychia congenita would be considered, it would probably be, the best approach to that is to try to figure out and anticipate when you're going to be doing something, when you're going to be up on your feet or walking a long way. For most people, that's a pretty significant irritation. And then starting out with a dose of ibuprofen, for example, that usually helps alleviate pain when you have it. I can't give you a hard number because it's so variable between people. But you want to be taking enough that will make a difference. But again, not so much that you're exceeding the recommendations. I'm going to talk a little bit about that in a second too. Okay, so Tylenol, you can take 4,000 milligrams or 4 grams of that in a 24-hour period. And for most people, it's about 600 to 1,000 milligrams every 4 to 6 hours, again, depending on what you're taking. So to make this more effective, just like you said, we talk about pre-medication, trying to avoid catching it, so thank you. I'll put you on the slide from now on. It's something, it requires, you have to plan ahead to be able to do that. And remember, it takes about an hour after you take the medicine before you really start noticing how much it's going to help. I do think overall that pre-medication is a better approach, just taking into consideration the idea of not exerting yourself more than you can handle. Combination therapy is another good way to approach this too. Remember that Tylenol and ibuprofen and NSAIDs are metabolized very differently. So if I take, say, ibuprofen and then I need to wait, say, 6 hours or 8 hours later before I can take it again, what I could do instead is I could wait 3 hours and take some Tylenol, and then 3 hours later take more ibuprofen. Because they're metabolized by totally different pathways, you aren't going to overdose because you're just using different pathways in your body to do that. Alternating that way, you can sometimes bridge the gap, so to speak. And so that's one way you can do that to make your pain medicine a little bit more effective. People that tend to alternate also tend to use less high doses. So you're not reaching you're not maxing out, say, how much Tylenol or ibuprofen, you're using a lower amount. So that's kind of a useful way to approach that too.
Well, you don't always catch your liver or your kidneys.
Exactly. You're within the manufacturer's specifications that way, not going too high. I'm going to talk briefly now about prescription painkillers, which are in 3 main groups. So tricyclic and antidepressants were originally designed, as the name suggests, to help with emotional feelings of depression. What people have borne out in studies, though, is that these antidepressants actually help in chronic pain. And that assistance is actually, the way that they help pain is actually independent on how well they treat depression. So there is some direct interplay between these medications and chronic pain. Antidepressants, because the prescription medicines tend to have a bit higher potential for side effects, and I've listed some of the ones here. So these are medicines that you want to make sure that your physician who prescribes them is aware of what you're taking and they're moderating the doses. But this is one effective way, especially in working on chronic pain. So I want to ask a question on this one like the other ones. Has anyone been prescribed antidepressants or any of those before chronic pain before? And then I guess if you're answering already, so this is if you've been prescribed them, not whether they helped. Okay. For depression. Okay. So if you've been prescribed them for pain or for depression, did you find that they were helpful at all? Did they help with the pain? Okay. So there were 2 people who said that they had, and both people said that it helped. So that's something to consider, I think. Another group of medications is called the anticonvulsants. These medicines were designed to help people that had things like epilepsy or would have seizures. Seizures are caused by defects in the way that nerves conduct signals to each other. Pain is conducted by nerves as well. And again, these medicines were determined to actually help with pain, especially pain that was caused by damaged nerves. So the examples I have here are ones called gabapentin or Neurontin and pregabalin or Lyrica. And so I'm just kind of curious to know, has anyone ever been prescribed these medicines to help with their pain? Okay. So, and of the people who were prescribed the medicines, did they make a difference? Did they help it at all? Okay. When there's only one, I guess I can't hide you with that anonymity. But one person said that they were prescribed it and they said that it made a difference. That's something to consider. I put the answer there. This is opium, in case you want to know what it looks like. That's the poppy. Kind of pretty. Opium is the plant that the morphine is derived from. There's a lot of medicines that have been derived. They're opioid-based medications. I listed a lot of the names up here. So opioid medications, I'm going to talk a little bit more about, because these are excellent pain relievers. They do a very good job at relieving pain. They have very low ceiling effects, meaning the more that is taken, it is a progressive and steady increase in the amount of pain relief. They don't top off like the other ones do. And they have a much more rapid onset of actions, dependent somewhat on how they're administered. If you take them as an IV, they're much faster than if you take them as a pill, but overall they're faster than most of the other ones. The bad is that they do have some significant side effects. There is a potential for abuse and addiction, usually in the context of treating chronic pain. And there's a lot of doctors that aren't comfortable prescribing these because of the potential for that abuse and addiction and for the side effects. Especially a lot of dermatologists, because they don't routinely treat pain, don't like to prescribe these. Side effects, so it causes constipation and nausea. Nausea in some people, constipation in everyone. It can make you feel very out of it, just thick. And I've never taken them, but patients say they just feel like they just can't even think. There's some cloud in their mind sometimes. It can cause severe itching because it can actually cause, like we get with hives, it can make that happen to you if you take these. And then there's, of course, the more infamous, the dependence and addiction that can happen from it. Has anyone ever been prescribed opioid-type medications to help with their pain? Okay. And so of those people who have been prescribed the medicines, did you find it helpful? So of the 3 people that were prescribed, all 3 said that it was helpful for them. So it's something to consider, and it's kind of going back on this. I know that the opioid pain medications generally are used for acute pain issues. I gave the example of when people are in the hospitals after surgery. It's generally if people want to have kind of a more chronic approach, or use them in a chronic setting, seeing a pain specialist is often the best way to approach that, because they know how to dose these in a way that will try to minimize the side effects for you and get the most out of them. So I want to just do a quick summary that there are a lot of ways to approach pain. There's behavioral and procedural changes, like we talked about, with what you can do to the calluses. There's the use of prescription and non-prescription pain medicine. Strategies that usually are helpful are trying to stay ahead of the pain and planning for it. And that physicians can help with your pain, but sometimes they need to be trained a little bit as you get to know them so they know how to help you. And with that, I'll be done. Yeah?
My wife takes Celebrex, and I was wondering if anybody else took Celebrex.
Okay, so those 2 cards give you up and down. Anyone's taking Celebrex? Or Celecoxib is the other name. Okay. All right, so those who have taken it, has it made a difference in their pain? Okay, and then, so Celebrex is it's a modified NSAID. It's one of the new generations of the it's like kind of ibuprofen, but it's much more selective and is considered more potent. So that's can be kind of grouped in that same category with similar type of side effects. Okay, any other, yeah?
I took Wellbutrin, Zyban, to quit smoking, and I don't know whether it helped on the pain or not. It didn't cure me.
I don't know about when I looked up the different antidepressants, I didn't look at Wellbutrin, which is it's a well-known antidepressant.
Right.
It has similar types of action, so it would make sense that it would help as the way that the other generations. Did you find it made a difference?
It did.
It did. Okay. So that means that's 4 out of that's.
So, do the SSRIs help pain? So the Prozac,
Yeah.
They also are thought to have not just the tricyclics.
Yeah, that's a good point. I made the point of I isolated the tricyclic antidepressants, but the newer ones like Prozac, Paxil, Wellbutrin, and Lexapro. Lexapro also. Those are all variations of the newer generation antidepressants, and those also have been implicated in reduced chronic pain as well.